Hi, are you the nurse?
Yes.
Let me just unglove.
All right. Oh, sorry.
No worries. I can grab a pair right over here. I got a pair of meetings here, Jason.
Oh, okay.
I'm Jason. This is Rudy. What's going on?
Hi.
Rearranging your room here.
Yeah, Mr. Drafton, he has been on the floor for 2 days. He was responding well, but now he's not answering questions.
Okay.
Yeah,
Is he alert? Oh, sorry.
Sorry.
Go ahead, bud.
So is he alert at all, or is he really looking completely uptime?
His level of consciousness seems disturbed. I
Hey.
don't feel he's alert.
Yeah. Okay. Yeah, we're just moaning at this point.
Yeah.
Still
Stats
tracking
are-
along. Stats are all right. Let's get that collar on him here.
There's a
And there is
episode
no-
of trauma.
No neck injury. He has some X-rays. I can drop them. He's okay. His head and
His
neck.
neck
are-
has been
Is that-
cleared.
Yeah.
Is that not gonna be
Yeah.
clear? Okay.
Yeah.
Wonderful.
Yes, he's okay.
Okay.
Here is his neck and the head.
Okay.
So let's just keep on the airway breathing situation.
Yeah. So, I mean, with his level of consciousness, we're gonna have to tube him before we go down.
Yeah, but does he have IVs right now?
Not
Is it-
yet.
Okay.
Nope.
Can we get 2 large IVs started
Oh.
on?
Preferably 2
Okay.
18s if
Yes.
we can, or bigger.
18 or bigger?
Yes, sure.
Wonderful. I guess his name when we came in, what was
He's just moaning.
his moaning? Alright.
We can continue until
Sounds
the
good.
IVs are in.
Sir, with FlightCare, we're going to be taking you down to Saginaw today. Can you open your eyes for me? Not really. Okay. Head.
You want 2 IV lines, right?
Yes, please.
Oh, okay.
I'm going to stop that.
Yeah, if you want to start prepping for an airway, we're going to have to.
And do you want some fluid for him?
Yes.
Yes, please. Let's open up a
How
liter.
much do you want? Oh, okay.
Put the liter wide open, please.
Oh.
Is he cold at all?
Yeah, his
All right.
temperature is 97.
97?
Resting temperature. Yeah.
Alright, so let's
Right.
go ahead and just get him a liter of warm
Yeah.
fluids.
Okay, this is one.
Wonderful.
Okay.
And actually, if there's, did we check lung sounds?
We've
Make
not
sure
checked
there's,
on sounds yet.
just want to make sure we don't have any CHF related issues.
He has some decrease air on the right side, and I have his chest X-ray.
Okay.
If you want.
Are you thinking this is pneumonia then on that right?
Mhm.
I don't see any.
No, I don't see a pneumo. Right side. Left side is awfully consolidated. Or
He
right
was
side,
laying
sorry.
on his right side.
He was laying on his right side,
Yes.
okay.
Okay, so it could be just all headline pictures.
Yeah, because atelectic, we could be dealing with like a aspiration pneumonia as well. Likely. Quick listen, John.
Yeah.
So as we prepare, we're going to have to intubate them at some point. We're going to power these couple liters in if there's no contraindications for this.
Yeah.
Did you guys do any lab work or anything
Yeah.
else?
What do you want?
Did you draw stuff? I mean,
Yes.
the CDC, comp,
Yeah.
troponins, lactic.
Yes.
Did you get a urine or is there a Foley in place?
There is a Foley in place.
All right. And what does that urine look like?
It's like a tea color.
Okay,
Okay.
that's what I need.
Yeah.
So lots of IV fluids right now.
Yes.
The potassium's 7.4, so we'll have to address
Yeah,
that
we
as
have
well.
to. We got peak T waves over there as well.
I have an EKG too, and initially, if you want it,
I still can't see through her head. 4.2 is acute renal failure,
Yeah.
so he's in rhabdo.
Yeah, we are in full on rhabdo. So with that BUN, the creatinine, and the potassium 7.4, I'm not liking any of that.
We'll address this potassium.
Yeah, we'll get.
Are you pulling up the EKG or no?
Yes.
Okay, so we got the peak.
Peak T waves.
So let's go ahead and treat this.
Mhm.
We're going to give a couple liters normal saline.
Yep, wide open.
And let's go ahead and give a gram of calcium,
Yep.
kind of regular insulin IV,
What do
Solid.
you want to do then?
1 amp of calcium,
Okay.
10 units of regular insulin IV push,
Okay.
1 amp of dextrose, 1 amp of sodium bicarb,
Okay.
and we can actually start an albuterol treatment
Yep.
as well. And he really isn't a candidate yet for oral KX-late until after we intubate. And
Yeah.
We'll do that.
Yep.
So
Okay.
Sounds good.
he's not a dialysis patient or anything like that.
No, no.
What's our weight on this
He's
gentleman?
100 kilograms.
100 kilos?
Yes.
Sounds good.
So our goal is to try to resuscitate him before intubation.
Correct.
Okay.
And with IV fluid. So I'd like to get him 2 liters right away and to try to get his urine output
Okay.
increasing as much as we can right now.
Okay.
A couple hundred mLs an hour would be great as an output. So.
Correct.
Okay.
Our blood pressure looks like it's responding to our fluid
A
resuscitation
little bit.
so
It's
far.
going in the right direction. The stats are still a little iffy.
Yeah, I still don't know the saturations. We've got that albuterol treatment going for the Hyper-K.
We're starting to make a little progress on that. We got a map of 70, so I feel like we can, as long as there goes our stats down in the 90s. So
Okay.
I feel
So
like
he has 2 lines of fluid, 2 liters are going on now. I'm giving him 10 units of insulin,
okay.
and this is the calcium is
Okay.
in, sodium bicarb
Okay.
is
Fluids we flush
in,
between.
and exactly,
And a dextrose as well.
yeah. We flushed, and now 1 ampoule of dextrose.
Wonderful.
Okay?
Yeah, at 90%, we're either going to bag them and work on this blood pressure a little bit.
Yeah, I like bagging him here while we work on the blood pressure.
Is this our bag belt mix?
Yes.
Okay. So I think we're going to have to start a Levo drip as well.
Okay.
That's
Levo drip, right?
Levofed drip. Yep. We'll start them at 10 mics a minute right now. And then we're going to prepare for intubation as well.
Okay, the intubation set is already there.
Yeah, but we got to get some meds on. So
Oh.
first I want to do the Levofed drip.
Okay.
We got to keep his nose above water at 92 systolic. So.
Okay. So the Levo drip is given.
Okay. And we're going to bag him, and if he needs a nasal airway, we can not do that here.
There is one over there. You want nasal cannula?
No, a nasal pharyngeal NPA.
So we could also toss in line
It's not.
and
It's
right
not.
on here. If you want.
There's an oral. Not there. It's right
There we go.
This into the line here.
But we'll pretend it's the like.
This is what you all were doing on us.
All right. So let's try to bag them up on 100% oxygen. We'll adjust our levo to probably at least a systolic of 120. I feel like most comfortable with that.
Have we seen a pelvis X-ray? Because we were complaining of some
Yeah,
pelvic
there
fractures.
is. Yeah, there is. So his blood pressure is improving.
Wonderful.
Oh.
I do not like that. I don't like the.
What do you?
I'm looking.
The right hip looks like I don't have a great view of it. So,
Yeah, it's spliced.
Yeah.
what do you call this?
Yeah, pelvis is stable.
Belly though is, but
He was standard before he lost his consciousness. He was complaining of his belly hurting.
Have we scanned him, or can we do it fast, real quick?
Oh, not yet.
Not yet. Okay.
Our hemoglobin is stable, wasn't it?
10.
10. Okay,
Yeah,
so I would
age-
also it's probably need some blood.
Yep.
As well.
That's where I was leaning towards.
All right. So 92 is how's his level of
Fast is
consciousness?
negative, by the way.
Fast is negative.
Yeah.
All right. Stats responding a little bit. You said blood pressure is coming up a little bit as well. So what do we want to use for intubation?
I'm thinking. I don't love etomidate, but etomidate and rock would work fine.
That's fine.
Do what? 30 of etomidate and.
30?
60
How much was he in?
100
Okay.
kilograms.
So 30 of etomidate, and then the rock would be 6 to 12.
Just 100 of that because it's 0.6 to 1.2.
Yeah.
100 kind of fits on
Yeah,
it.
works for me.
How much?
100
100.
milligrams of rock
Okay.
and For continuous sedation, we'll consider propofol if his blood pressure can handle that. So.
How much propofol?
We'll start at 20 mics per kilo per minute,
Okay.
and then titrate from there.
Okay. You want me to give these medications now?
It might be accommodating around.
Okay.
I'll take over bagging if you want.
Yep, sounds good.
We had attached end title, and I don't see that yet.
Yeah. They are given.
Both of them are in?
Yeah.
Okay. Suction is available over your right.
That's good.
Ready?
Yep.
We'll listen along songs for us. Are you in?
Yeah.
I've got the two.
Sounds good. Turn my style a little bit.
Do I have good color change?
Yes.
Okay. Can you check one songs for me, please?
His chest is rising.
Wonderful.
Both sides.
Yeah.
Anything over the belt?
What do you mean?
Any sounds over the belt?
I hear the vowel sounds on the right.
No, any. Okay.
No air though.
No, no. You mean?
Pop this in real quick.
Yeah.
No.
Yeah, go ahead and disconnect. I've got this.
There we go.
Pop this one off. And then I'll do this while you secure the two.
Sounds good.
Stats are 99%.
Wonderful.
Blood
Blood
pressure's
pressure's holding. We're not killing you with intubation.
Is 100 kilos his ideal body weight? Vital volume of 600 under ventilator. Respiratory rate of 16. PEEP will go a little bit higher because he's probably a little atelectic. So maybe we'll go PEEP of 8 if his blood pressure can handle that. We've also got a leave with a drip that you can adjust.
Simulation is complete. Thank you.
That's no problem. Cuff holds.
I can handle that.
Okay.
Thank you.
No worries. I'm just gonna disconnect that so I can get through here without
Yeah.
tripping myself.
Appreciate it. Okay, thank you.
Nice job. How do you guys feel?
That's pretty straightforward,
Yeah.
right?
Yeah, I mean, it's a mixed bag of possible traumatic hemorrhagic loss plus the rhabdo with obvious AKI and
Right. And one more thing. You guys hit it.
and the hyperkalemia.
And that communication, as usual, is always good. You're trying to figure out a few things at the same time. So, these things are just like in real life. We're never going to be, all right, we're going to do this, this, and this, and we're out. Just there's a lot of figuring out the medications you guys got. You wanted to go through. Someone said, let's go through the ABCs, and you did. You recognize that the GC is going to be low. So at some point, back of our head, we are thinking of intubation. I like the IDs, the warm, large bore. You guys were specific. And then the chest X-ray. The chest said it was just pulmonary edema, but you're telling me this alcoholic is being on the floor. Like I thought aspiration.
Yeah.
It's the right
Yeah,
side also.
he called out the aspiration.
Yeah, because it looked just
I mean, it did.
It
garbage.
didn't look like a infiltrate like a pneumonia, but
Yeah.
he's laying on his right
Yeah,
side,
he's
so he
laying
could
on
be
his right side.
atelectic on
Right.
that side too.
So all very good. I wanted you guys to see the X-ray of the pelvis. You guys hit on it. Why? In terms of hypotension.
Yeah, so, I mean, we can lose a ton of blood into the pelvis.
How?
Well, open book pelvic fracture being one of them. I'm
Right.
concerned right here. That looks. But
I don't see any diastasis.
Yeah, you're right. It's not. There's no diastasis.
Okay. But that's definitely.
So that's
normal.
That's normal.
This
side.
one is the
Yeah.
you don't see a good neck. Like this one, you can see the neck.
I
So
see
this
that
one,
there.
it looks like it's
So it's either a femoral neck or what they're calling as a right acetabular fracture, I actually don't see. So this case,
They're
I
calling this a
actually-
right
yeah,
acetabular
which is hard to
fracture?
see. Yeah.
Yeah.
Maybe on CT.
But yeah, it has to be on CT because I'm not seeing it on this.
Is that just, to me, it honestly kind of looks like a 4 exam, too.
I think
So the
we
leg,
need
the
a
right
little
leg
bit
could
better
be
look.
Yeah.
could be rotated
It's
either
just,
way.
it could be rotated or it could be fractured.
But you guys are thinking about it. You
Yeah.
saw the abrasion on the right hip. You might need blood. Then
Definitely need blood after we get the 2 liters of
Yeah,
blood.
with
So
that hemoglobin
because
of 10.
yes,
hemoglobin's going to be
If
7.
it was grandma with hemoglobin of 10, I guess I'd be a little bit more comfortable that it could be just grandma with age, but this guy I wouldn't expect a hemoglobin.
And obviously, it sounds like you guys have dealt with hyperkalemia before.
Mm-hmm.
Pretty once you see that.
Yeah, they threw a weird one at us our last sim lab. I don't think you were here.
I say,
They had an LVAD with hyperkalemia. It's like an LVAD EKG looks. I don't see a lot. And it was a bullshit
Yes.
scenario.
I said Lucas and I had a decent one that we brought back here. One of my first flights. Lucas, Rod, and I had a decent one we brought back here. One of my first flights back. It was, very similar picture, except swap out alcoholism with IV drug abuse and, an unknown downtime.
If you had a choice, what medication of the ones you called out, and they're all correct, and the right dosage also, for the hyper-K, if you could give one first, what would you rather have?
Oh, calcium's first. I called that out, but she
Yeah.
ended up switching it around. And
Okay. No, that's
she's
fine.
like, I'm giving this.
Right,
this,
right,
this.
right.
All right,
But
she
yeah,
gave
I
a
heard-
second.
right.
Yeah.
Calcium's first.
Calcium's first.
Now, splitting hairs, calcium gluconate or calcium chloride?
Whatever's available, because whatever's in the top drawer of
Yeah.
that crash cart is what I'm going to give.
Okay.
And it's really up to each institution.
Do you know what
So-
the difference is?
Oh, one's better bioavailability
Yeah.
or something. Gluconate, I think, is
Gluconate
no
is-
chloride's better than gluconate, right?
Correct.
Yeah.
But chloride it's got higher calcium, but if it extravasates, you get an
It's a higher
issue.
risk.
So it should go through a peripheral. Obviously,
Central.
not central. So that's why, at least in the ER, in the beginning, we always calcium gluconate
Gotcha.
to stabilize that memory.
Mhm.
That's the reason. The other stuff helps it go intracellular, right? And then the stuff that helps eliminate volatility,
Yeah.
at least in that.
I would prefer not to give KX late in a flight, but
And
You just give it orally,
Yeah.
not
Right, right,
rectally,
right.
Yes.
and then it's somebody else's problem at that
he's
point.
gonna find himself again.
so then one of the first EKG changes that you should see on hyper-K is
That T wave. Well, with treatment, we should see that T wave starting to come down.
Are you
Correct.
saying with treatment or
without.
Without.
So the peak T waves or a faster rate
Right.
often is common with
Then what? If it continues to go high, what happens to EKG?
it can sign out.
Yeah.
Is that what you're asking?
Yeah, it starts to widen out.
Mhm.
It starts to become bradycardic
Mhm.
because of the conduction delays,
Yep.
and then it just starts to have a sine wave. I looked at something 2 nights ago. How about hypo-K? Not part of this, but since we're talking.
What about it?
What do you say on EKG?
It's often tacky, and the problem is you can't replace it fast enough.
Right. What do you say on EKG instead of a hyper-T?
Would it be a flatter?
Flatter,
I
yeah.
guess, I don't
Yeah.
know.
Yeah, flat.
So the picture I saw, which I never thought about it, but it made sense, is if a hyper-K, just pretend you're pinching the T wave and you're pulling it up. And then on hypo-K, it was a finger and you're pushing it down,
Okay.
so you actually get an inverted T,
Okay.
but then because of the slack,
Mhm.
you get a up U wave.
Yeah,
Okay.
U wave following.
Yeah.
So.
I think those were we talked about the pelvis, no need for the no need for the pelvic binder, and then the RSI, you guys were right on with the accommodate and the rock, no sucks,
No
No
sucks.
sucks.
Contraindicated.
and
Yeah.
then probe, but then pending blood pressure,
Yep.
so right on. If the blood pressure wasn't too good, what else could you do for sedation on the right home?
Fentanyl versus push. My backup game plan if we didn't have. If we're,
Versed doesn't last very long.
it doesn't last
I
very
know,
long, but
it is. I
we
would
could use ketamine.
ketamine is
You
I
know
would
what I mean?
I would lean towards that.
I mean, in the ER we'll do drips of fentanyl and
Yes.
Versed, but Versed doesn't touch blood pressure, which is okay.
Yeah.
Any questions?
Yeah, if you get drips, you don't have to
Yeah.
push it every
Right.
5
Yeah,
minutes.
yeah,
Right.
and that would be something I would be talking to the facility if they
Yeah.
are willing to liberate us
Right.
some fentanyl and Versed drips to take and then we just waste when we get back here.
I don't see any reason why they would.
Yeah, I'd be game for that. I really hope that we do add propofol into our
I think
formulary.
we could.
Yeah. Well, I mean, like the formulary we carry, we have it at Guardian, and I really got great results with it up there.
Just with these softer blood pressures, I
Yeah,
think
oh
that
yeah,
we're going
the
to be
softer.
pushed into increasing our levo.
Yeah.
Oh, and you guys, I think wanted. Yeah, I have Levo here too.
I see. Was his? No, I don't think his white count was really that elevated. Where
What's the? I think it was 13.
13, okay.
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 Going down a
Not going down
route
the
just
sepsis route.
yet.
Right,
So.
right.
Because that's-
There
that
wasn't a lactic on there.
Yeah, that was the only, that'd be a caveat I would consider with the possibility of there being sepsis. If he's not really responding well to that levofed, which he seems like he was, adding in like some vasopressin.
Yeah. I mean, he said he was a little acid. Yeah, there was metabolic acidosis also.
Mhm.
So yeah, you could.
Yeah,
It's all good.
and especially like if we're going to get
Discussions.
too into the blood,
Mm-hmm.
then we might want to consider that higher.
All right. Nice job.
Mhm.
Nice job.
Thank you.
All right. Thank you.
Thank you.
Thank you.